Improvements in endoscopic imaging with high-definition endoscopes and image enhancement have augmented the capability to distinguish between hyperplastic and adenomatous colorectal polyps at the moment of their detection. Newer colonoscopes equipped with an image enhancement feature such as narrowband imaging, eye scan, or Fujinon intelligent chromoendoscopy detail polyp vascular and surface patterns to reflect the underlying histology. Therefore, optical diagnosis of colorectal polyps can offer real-time clinical decisions on management and follow-up without formal histology. Diminutive adenomas can thus be resected and discarded. Diminutive hyperplastic polyps in the rectosigmoid can be left in situ, and surveillance intervals can be communicated to the patient on the day of the endoscopy in situations where the endoscopist has high enough confidence in the optical diagnosis. This real-time optical diagnosis strategy has the potential to improve the cost-effectiveness and efficiency of screening colonoscopy. Ultimately, the integration of optical diagnosis into clinical practice will require endoscopists first to obtain the knowledge and learn the skills to differentiate polyp histology, and next to achieve and sustain high levels of performance. The American Society of Gastroendoscopy, in its Preservation and Incorporation of Valuable Endoscopic Innovations statement, has recommended thresholds above which a technology could be suitable to implement a resect and discard policy. These thresholds are a greater than 90% agreement between optically predicted surveillance intervals and those predicted by histology, and a greater than 90% negative predictive value for the optical diagnosis of adenomas when made with high confidence in the rectosigmoid column. Further guidelines towards implementation in practice have recently been published. The European Society of Gastrointestinal Endoscopy states that optical diagnosis of diminutive polyps can be practiced under strictly controlled conditions, which include the use of validated diagnostic criteria, photo documentation of polyps, and performance by experienced endoscopists who are trained and audited. Many groups have prospectively compared the optical diagnosis of colorectal polyps in real time using NBI colonoscopy with formal pathology. A systematic review and meta-analysis of 28 such studies showed that these groups, with mostly expert endoscopists, overall met the ASGE parameters for clinical implementation, with 93% concordance of surveillance intervals and greater than 90% NPV when 40% or more of polyps were hyperplastic. Fewer studies have evaluated endoscopies in community settings. 2 have yielded inferior results and served to highlight the importance of regular training as one of the vital steps for practice implementation. The development and validation in recent years of the NBI International Colorectal Endoscopic Classification as a diagnostic criterion for hyperplastic and adenomatous polyps using NBI, and the ready availability of robust training tools may facilitate standardized training and the practice of optical diagnosis. McGill et al. Hypothesized that high performance in optical diagnosis of diminutive polyps could be achieved and sustained over time in a group of endoscopists who used a validated endoscopic classification of colorectal polyp pathology following a standardized and continued training. They analyzed data from a prospective randomized trial on the optical diagnosis of colorectal polyps using NBI to measure NPV and surveillance interval agreement of individual endoscopists over time. Their results are reported in the study entitled "Endoscopists Can Sustain High Performance for the Optical Diagnosis of Colorectal Polyps Following Standardized and Continued Training." Background and study aims. The learning curve for optical diagnosis of colorectal polyps with a narrow band imaging is unknown. To forego histological analysis of diminutive polyps diagnosed optically with high confidence, guidelines recommend greater than or equal to 90% negative predictive value and concordance of greater than or equal to 90% for surveillance intervals predicted optically and histologically. We aim to study the learning of optical diagnosis for colorectal polyps. Patients and methods. We studied 5 endoscopies as part of a randomized multi-site trial comparing near-focus and standard focus views for optical diagnosis. They trained using a computer-based module followed by 10 real-time colonoscopies with pathology correlation. Endoscopists then optically diagnosed and resected all the polyps found during 558 consecutive colonoscopies, and diagnoses were compared with pathology. Endoscopists repeated the training module at the study midpoint. NPV and concordance of surveillance intervals for diminutive polyps diagnosed optically with high confidence were measured over time. Results. Endoscopists showed high diagnostic performance with a non-significant trend towards higher NPV in the second half of the study. For the 445 polyps in the standard view arm, the NPV was 88% in the first half and 95.8% in the second. 3 endoscopists in the first half and 4 in the second achieved greater than 90% NPV. Concordance of surveillance intervals was identical in the first and second halves at 98.1%. Conclusions. High NPV for the prediction of non-neoplasms with NBI was achieved and maintained in this group of endoscopists who participated in standardized and continued training. Both NPV and surveillance interval agreement indicated high performance in the optical diagnosis of colorectal polyps and exceeded thresholds.